Hello guys and welcome back to Count to 10. My name is Arnie and on today's pod we're going to be covering part 2 of Applied Cardiovascular Physiology. In today's episode we're going to be looking at the past SAQs related to this topic, and I've specifically highlighted 9 SAQs I want to get through on today's episode. Now before we get started, I want to wish good luck to all the candidates sitting their vivas next week, and I also want to say a big shout out and thank you to Celia for doing the live practice viva demonstration with me. That video is out on the YouTube channel and you can check it out along with some other live practice viva demonstrations with some other previous candidates. I also have a separate video with my top tips leading into the viva, which I recorded right after my sitting. I hope some of those tips make you feel a little less nervous going into the vivas next week. And just remember, the vivas are a way for you to show what you have learnt throughout your journey studying for this part 1 exam. So you should feel confident in yourself and your ability to perform on the day. Now going back to today's topic, let's dive straight into these SAQs.
1, 2, 3, 4.
The first SAQ I'm going to look at today, and I'm just ordering these going back from the most recent to the oldest, was from the 2024 first sitting, and it was a completely new question, which was, outline the mechanisms which cause each of the following after the release of an arterial tourniquet which has been in situ for 2 hours: hypotension, desaturation, and hypercarbia. This question had a 43% pass rate, and there's no model answer for this question yet. Going through the examiner report, I actually think this gives you all the information you need to make your own model answer for this question. So the domains they wanted you to cover in the examiner report are highlighted in the question itself. So looking first at hypotension, they specifically said this occurs because of the refilling of the vascular compartments. Other causes of the hypotension include arterial and venous dilation within the limb due to metabolic autoregulation, systemic arterial and venous dilation due to the increased hydrogen ions and other metabolites entering the circulation, and that within these 3 points, you need to describe the mechanisms for each of these and how they actually lead to hypertension. Then for desaturation, the points needed to be covered included upon reperfusion of the ischemic limb, there is an increased oxygen consumption and extraction, which results in a decrease in mixed venous oxygen content. This magnifies the effect of any shunt on the final arterial O2 content. Because of the addition of the mixed venous blood to the arterial blood, this has an overall dilutional effect. In other words, all they're trying to say here is that the blood that's returning to the heart after the arterial tourniquet is down is just deoxygenated. Therefore, this leads to a transient desaturation. The final domain for this question, which is the hypercarbia, needed to include the following points. Firstly, that after the tourniquet inflation, aerobic respiration in the limb ceases quickly, and therefore there is limited tissue and blood reserves for O2 within that limb. As a result, there's a reliance on anaerobic metabolism. The second point is, as there is a buildup of hydrogen ions from anaerobic respiration, this needs to be buffered by bicarbonate, and this is what forms the CO2 via the carbonic acid equation, not the CO2 that's produced in the Krebs cycle, because this also ceases due to aerobic metabolism ceasing. Now following tourniquet release, the 2 points mentioned here is that the hydrogen ion entering the circulation needs to be buffered, therefore more CO2 is produced via the carbonic acid equation, and the tourniquet release leads to an increased metabolic rate in that limb, which produces more CO2 when aerobic respiration resumes. In the examiner report, there was also a list of common problems and errors when answering these SAQs, and these were said to be inadequate explanation for hypertension, sometimes limited to vasodilation, failure to consider venodilation with increased venous capacitance and decreased venous return, only considering the effects on the vasculature within the ischemic limb or the systemic vascular resistance, but not both. Most candidates weren't able to cover all 3 elements of the question, and many candidates asserted that CO2 is a product of anaerobic metabolism. So that's a lot of information to take in from this examiner report, which is really helpful, and if I was to make a model answer for this question, I would start off by acknowledging a very simple and basic point, that is that this arterial tourniquet has been in situ for 2 hours. That's a significant amount of time where these changes can have a significant impact. If a tourniquet was just on for 2 minutes, you wouldn't really expect hypertension, desaturation, or hypercarbia. So the fact that they've mentioned specifically 2 hours means that in my mind, you should acknowledge that point in your opening sentence. Then I would divide this answer into the 3 domains being hypertension, desaturation, and hypercarbia. And with each one of these domains, in my mind, there's a specific point that you must mention. So for hypertension, this goes back to the principles of understanding the equation for venous return and the concepts of mean systemic filling pressure, venotone and venocapacitance, and arterial resistance. The other important component is understanding the local factors that affect regional blood flow. So simply put, when that arterial tourniquet is released, you get a new compartment where blood from the central compartment must go and flow into. This means that your overall mean systemic filling pressure is reduced, and if this is reduced, your venous return is reduced, and therefore your cardiac output is lowered. Additionally, the effects of this are exacerbated, say, for patients having a general anaesthetic, because our normal acute compensatory mechanisms for if cardiac output is decreased, which is an activation of the baroreceptor reflex leading to an increased sympathetic tone, are abolished or decreased with someone that's under a general anaesthetic. Therefore, you need to artificially increase the blood pressure in the venotone by giving the patient a drug, and commonly we use alpha agonists here like metaraminol to temporarily increase the blood pressure to compensate for the hypertension. The second point with regional blood flow is understanding the local mechanisms of regional blood flow. So this goes back to both the myogenic and metabolic autoregulation. Specifically here, the metabolic autoregulation is very important because you have a buildup of metabolites like potassium, lactate, and hydrogen, which are all causing local vasodilation. Therefore, they're decreasing the venomotor tone. This again, related to the equation for venous return, is going to be impacting venous return and leading to a decrease in preload and overall decrease in cardiac output. The point I think the examiners want you to make as a step further is understanding that those local metabolites will enter the systemic circulation and therefore can cause systemic, arterial, and venous dilation. Now, the second domain of desaturation is pretty straightforward to understand. You're leaving a limb ischemic and therefore it's void of oxygen. Not only this, but if we go back to understanding our oxygen dissociation curve, those metabolites, specifically CO2 and hydrogen ions, are going to shift our oxygen dissociation curve to the right, therefore increase offloading at the local tissue. So this combined effect leads to the mixed venous blood that's returning back to the heart to have a decreased O2 content. And that's why you get the hypoxemia secondary to the tourniquet release. The final point of hypercarbia relates to your understanding of the anaerobic and aerobic metabolism cycles. The key point to understand is that CO2 is produced as a byproduct of aerobic metabolism, not anaerobic. Anaerobic metabolism's end products are lactate. As a product, the lactate is going to produce hydrogen ions, and these hydrogen ions need to be buffered in some way. The most common metabolic buffer is the carbonic acid equation, which converts the hydrogen ions into CO2. Now, this CO2 can't escape the limb while the arterial tourniquet is up. It can only accumulate, but when the tourniquet gets deflated, that CO2 enters the systemic circulation. So that's one pathway by which CO2 increases. The second pathway is when that tourniquet is released, O2 now comes in with the new arterial blood, and the metabolic rate in those tissues is increased. That increase in metabolic rate leads to an increased production of CO2 through the original aerobic pathway. Again, clinically, what we might do to compensate for patients for this effect of hypercarbia is increase minute ventilation prior to tourniquet release. And while that's not asked for in this SAQ, I think it would be a good point to put in. So just to recap this SAQ, because it's new and there's no model answers, the equation you want to put in with hypotension is venous return and MSFP. The concept you want to talk about with desaturation is mixed venous blood and the oxygen dissociation curve. And the concept you want to talk about with hypercarbia, you want to talk about aerobic and anaerobic metabolism, along with the buffering via the carbonic acid equation. Moving on to the next SAQ, which was also from 2024 first sitting, which has been asked twice previously, that is, explain the physiological process that cause oliguria in response to hypovolemic shock. This had a 50% pass rate, and the examiner report stated that these were the domains needed to be covered in the answer: the sympathetic nervous system and understanding the role of this, especially its impact on RAS and ADH, the renin-angiotensin system and understanding why the RAS is activated by hypovolemia and how angiotensin II levels lead to oliguria, and finally antidiuretic hormone and understanding why it's released and triggered by hypovolemia and how it also leads to oliguria. For this model answer, I particularly like the layout from Amanda Diaz. I'm a big fan of an opening line, and here the opening statement describes and defines both hypovolemic shock as well as oliguria. So hypovolemic shock, as we've already discussed in part 1, is a state where the body is unable to meet its metabolic demand to its tissues due to an inadequate intravascular volume. This is characterized by a decrease in venous return, leading to a decrease in cardiac output. You see a decrease in blood pressure and a decrease in MAP. You get a decreased capillary refill time, and you get cool peripheries. Oliguria is defined as decreased urine output less than 0.5 mL per kilo per hour, generally for greater than 2 to 4 consecutive hours. And then you can divide this answer into a control arc. So here you have your detection systems. Firstly, you have your high pressure baroreceptors, and they become increasingly activated when volume depletion exceeds 10%. This leads to that classic pathway where there's increase in sympathetic output as well as a decrease in parasympathetic output. As part of that sympathetic output, the renin-angiotensin system is activated and the ANP pathway is decreased. To amplify that effect, you have the low pressure baroreceptors, which are the volume receptors that lead to a decrease in output, specifically of ANP, and as a result, an increased level of ADH. The other detection systems that we haven't spoken about before include the intrarenal baroreceptors, which recognize a decrease in MAP and as a result lead to an increase in renin release, activating that renin-angiotensin system. And another detection system that we previously haven't discussed are the osmoreceptors. These are located in the circumventricular organs, and what that means is that it sits outside the blood-brain barrier, therefore can detect changes within the systemic circulation. The osmoreceptors are really sensitive to changes in osmolality, detecting changes up to 1 to 2%, but less sensitive for changes in blood pressure, needing changes of up to 10% to have an effect. So those are the main detection systems in our body, and the effective mechanisms of these systems include the effects of ADH, which mainly works on the kidneys, specifically the collecting ducts, to bind to V2 receptors to increase aquaporons so that water can be reabsorbed, as a result leading to decreased urine output. The second effector mechanism is the increase in sympathetic activity, which we've already spoken about. So this has multiple multi-system effects. Centrally, you can have a stimulation of your thirst centers. Cardiovascularly, you get increased cardiac output by increasing heart rate, stroke volume, and venotone. Renally, you get constriction of the afferent and efferent arterioles, limiting the blood flow through the glomerulus and leading to a decrease in GFR and as a result, decrease in urine output. And then directly, the sympathetic nervous system also activates renin release, leading to the start of the renin-angiotensin system. There's two major end results of this system that lead to oliguria. The first is the production of angiotensin II. This is a potent vasoconstrictor which increases systemic vascular resistance by binding to specific angiotensin receptors, as well as constricting the efferent and afferent arterioles, further limiting the blood flow and decreasing GFR. And the other effect of angiotensin II to stimulate the hypothalamus and the posterior pituitary to increase ADH and to create thirst in our body. Now, the second endpoint of the RAS is to produce aldosterone, and this has direct effects to increase sodium and water retention, specifically in the distal convoluted tubule, and if you increase water and sodium retention, your net result is decreased urine output. So for this SAQ, thinking about those detection systems and the effector mechanisms is the way I would structure my model answer. The next SAQ we'll look at is from 2023 second sitting, which had a really high pass rate of 85%, was described the immediate cardiovascular responses to a sudden loss of 30% of blood volume in a healthy awake person, and how are these responses different in a patient undergoing anesthesia with sevoflurane? Really, for this question, my model answer would be focused on making things as simple as possible. And so again, to start off, I would have a brief definition and a quantification of the degree of blood loss mentioned in this question. Specifically, 30% of blood volume loss is considered class 3 shock. So this is severe and potentially life-threatening. Also in this question, they've asked for the immediate responses. And in my mind, that involves 3 important responses. Firstly, talking about the baroreceptors, so mainly the high pressure ones, which will be the most important, and then the low pressure to decrease ANP and increase ADH. Secondly, the sympathetic nervous system being activated, and this can be attributed to the baroreceptor response, leading to the cascade of events that we've already touched on in our last SAQ. And thirdly, the endocrine response that helps to keep and preserve what's remaining of the blood volume. The additional point you could put in part 1 of this answer would be the mobilization of blood reservoirs as a temporizing effect, and these reservoirs that were spoken about previously mainly involve the splenic circulation and the skin. Then the second part of this question, which is how sevoflurane affects these responses, mainly goes back to how the sympathetic nervous system and the baroreceptor responses are ablated or diminished compared to a healthy awake individual. Additionally, you can put the direct effects of sevoflurane as well, which is the fact that it has a negative inotropic effect. It leads to vasodilation, leading to an overall decrease in MAP, and that peripherally, regional blood flow might be altered, so those blood reservoirs that we have may not be as effective as a temporizing measure. The next SAQ we're going to review and spend a bit more time on was asked in 2022 first sitting with a 30% pass rate, which was discuss the physiological effects of infusing 2 liters of Hartmann solution over 1 hour in a conscious, healthy, euvolemic 70 kilo adult. The latest examiner report for this question listed the common errors in people's answers. This included common misconceptions like thinking Hartmann solution leads to hyperchloremic metabolic acidosis, or other errors like not recognizing that Hartmann solution is slightly hypotonic, or that the lactate in Hartmann solution is very tiny when compared to the daily lactate production, or just simple errors in not understanding the efferent limbs of both the high and the low pressure baroreceptor systems. In my mind, this is actually quite a hard question to make a model answer for, because there's a lot of components to cover, and the 2019 examiner report actually has the domains I think you should use to write out your model answer. This begins with firstly understanding the composition of Hartmann's, and in my mind comparing this to the composition of plasma. So Hartmann's has a sodium content of 131, a chloride content of 111, a bicarbonate content of 29, which is given in a bag as lactate, a potassium content of 5, a calcium content of 2, and an osmolality which can vary per brand, ranging from 250 to 270. The next heading would be water distribution. This goes back to the principle of understanding that extracellular fluid can be divided into 1/4 intravascular and 3/4 interstitial. Therefore, when you infuse 2 liters over an hour, 500 ml should stay intravascularly and 1500 ml would distribute interstitially. The key thing to understand here is that that is the steady state distribution of the whole 2 liters, and the Ketamine Nightmares answer reports that the half-life for this distribution is approximately 5 minutes. This would lead on to my next heading, which would be the cardiovascular considerations of these effects. The main thing you want to get at here is that you get an increase in preload due to an increase in mean systemic filling pressure. This leads to an overall increase in cardiac output. However, given that this infusion is over an hour, this increase in cardiac output is only marginal. The reason it's marginal is when we talked about the control of cardiac output, we said that the majority of blood stays in the venous circulation. The venous circulation has an ability to venodilate and compensate for an increase in volume. Therefore, because this infusion is going over an hour, you get that compensation occurring, which leads to an overall smaller increase in cardiac output as compared to if you were just to give this 2 liters stat into a patient. And so a key point you'd want to write is that there's minimal change in a healthy euvolemic patient if infused over 1 hour. What's really important, and the next subheading, is the neuroendocrine effects, because these are the effects that are going to lead to that eventual 2 liters of fluid being excreted out of the body. And the way that's done is mainly through the low pressure baroreceptors. So these detect that high volume stretch in the heart and lead to both an increase in ANP and a decrease in ADH. An increase in ANP leads to an increase in urine output, and this is done by dilatation of the afferent arterioles, leading to an increase in GFR, as well as a decrease in the reabsorption of sodium and chloride. Combined with the effects of ANP, a decrease in ADH also leads to a decrease in water retention within the collecting ducts, therefore increased water excretion in your urine. Now the last point in this answer is the additional effects of giving Hartmann solution. So this involves the weird things like the metabolic effects. So what happens to that lactate? That lactate in the Hartmann solution can be a form of energy by conversion to glucose. The other weird effects to mention are the change in osmolality. Because Hartmann's is hypotonic, it can lead to an activation of the osmoreceptors, but to calculate the osmolality, you have to consider the total blood volume. Adding 2 liters of slightly hypotonic solution actually doesn't lead to a major change in the overall osmolality. So like I said, this is a tricky SAQ, and no wonder it's had a low pass rate, but the domains you want to hit in your model answer is the composition of the Hartmann's, the initial distribution of the Hartmann solution, the cardiovascular consequences of that, the neuroendocrine consequences of that, and then the extra additional stuff like the osmolality and what happens with the lactate. Now the next SAQ, which is from 2021 second sitting, is explain the effects of intermittent positive pressure ventilation on cardiac output. This is an examiner's favourite and has been asked 4 times previously, with the last time it was asked having a 50% pass rate. And really, I think we've gone through this concept quite well in part 1 of this topic. So really what I'm going to do is just read out what you can't miss as per the examiner report when answering this question. All you need to do to pass this question is break it down into what happens in the inspiratory and expiratory phases, and then accurately describe the changes in preload and afterload that occur in the right and left ventricle, and integrate this knowledge to explain the overall impact on cardiac output. I think the Ketamine Nightmares model answer does a great job of summarizing these effects, and I'll leave it at that, and we'll move on to the next SAQ, which was asked in 2019 second sitting, which was briefly explain the cardiovascular effects of a central neuraxial blockade. This had a 60% pass rate, and the examiner report stated that the major domains assessed in this question were a definition of a central neuraxial blockade, including understanding that spinal and epidural routes may have different effects, the role of the sympathetic nervous system as a cause of the CVS changes, the primary CVS effects of the neuraxial blockade at differing levels, and the baroreceptor-mediated reflex responses that occur as a result of these primary effects. So my model answer for this question would hit those points highlighted in the examiner report, starting off with the definition of a central neuraxial blockade, stating that it could be either a spinal or an epidural anesthetic. Additionally stating that the sympathetic nervous system extends from a thoracolumbar region and that the preganglionic fibers for the sympathetic chain can be blocked, leading to different severity of cardiovascular effects. The next point would be talking about the level of the block and what effects you see with this. So I break this down into a sacral block, a low thoracic lumbar block, a high thoracic block, and then a brainstem block. With a sacral block, there's no sympathetic chain, therefore there's minimal effects on blood pressure. With the low thoracic to lumbar block, you can get a decrease in systemic vascular resistance due to a decrease in venotone at that level. However, the normal baroreceptor reflex are still preserved, therefore above the level of the block, you have an ability to compensate with an increase in sympathetic tone to maintain normal cardiac output. When you start getting to a high thoracic block, this is when you specifically start to block the cardioacceleratory fibers that extend from T1 to T6, as well as the normal baroreceptor reflex that increases sympathetic tone. Therefore, your ability to compensate for a high thoracic block is diminished compared to a low thoracic lumbar block. Finally, at a brainstem level, you're directly inhibiting that sympathetic chain, and what you're getting is unopposed vagal tone, leading to both hypotension as well as bradycardia. Now, the other point that I would put in with the level of block is that this is talking about a spinal anesthetic. With an epidural anesthetic, the effects on the sympathetic nervous system are markedly less than compared to a spinal. This is because there's less penetration of that local anesthetic into those preganglionic sympathetic fibers, and with a lumbar epidural, you get very minimal effect on the cardiovascular system. With a high thoracic epidural, you might get some penetration into those cardiovascular fibers, and so therefore you can expect some degree of cardiovascular instability as compared to a lumbar epidural. Now, to finish off this question and talk about the cardiovascular response and the compensatory mechanisms we have, you should be able to see a theme with these mechanisms. These involve the high pressure baroreceptors that we talked about, leading to the increase in venotone, heart rate, contractility, and stroke volume, the activation of the renin-angiotensin system, leading to the production of angiotensin II, causing venous and vasoconstriction, increasing ADH, increasing sodium and water reabsorption, decreasing the effects of ANP, which helps to decrease natriuresis and keep the blood volume high as a compensatory mechanism. And then additionally, there are things that we could do to help aid these compensatory mechanisms. This may involve pre-treatment of a patient with a fluid bolus prior to a neuraxial, or the use of alpha constrictors like metaraminol to offset that venodilation. But the key thing I would put at the end of my answer is the high risk groups in which a central neuraxial blockade may lead to an exaggerated cardiovascular response. These would specifically be the pregnant population, the hypovolemic or shocked population, or those patients that have a fixed cardiac output state, such as severe aortic stenosis or severe mitral stenosis. The next SAQ we're going to look at is from 2019's second sitting, with a really high pass rate, which was described the respiratory and cardiovascular changes associated with a carbon dioxide pneumoperitoneum for laparoscopic surgery. Here in the examiner report, the domains assessed in this question were the effects of the increased intra-abdominal pressure on the respiratory system and the effects of the increased intra-abdominal pressure on the cardiovascular system. They also wanted you to talk about how the CO2 absorption will affect both the respiratory and the cardiovascular system. And you could also gain extra marks by talking about additional things, which in my mind relate to how a change in position during pneumoperitoneum will either exacerbate the effects on the respiratory system or the cardiovascular system. So my model answer for this question really is divided as per the examiner report, with one section talking about the intra-abdominal pressure itself, and the second section talking about the effects of hypercapnia. Then within each of these two things, you can break it down into the effects on the respiratory and the cardiovascular system. So firstly, talking about the intra-abdominal pressure, the effects on the respiratory system go back to talking about how there's cephalad displacement of the diaphragm and the effect this has on various lung volumes. The most important being FRC, and FRC is reduced secondary to this, which can lead to atelectasis, shunt, hypoxemia, and small airway closure. Additionally, lung compliance is decreased, and this can lead to increased peak airway pressures, increased risk of barotrauma, and these effects would be further exacerbated in patients that already have restrictive lung disease or those patients that are obese or morbidly obese. Then the cardiovascular effects can be divided into the stages of the application of the pneumoperitoneum. Initially in part 1, we described how the stretching of the pneumoperitoneum can lead to a vagal response, which can lead to both bradycardia and hypotension. Then you have the direct compression on the venous system, leading to a temporary and transient increase in preload, leading to an increase in cardiac output, followed by ongoing compression of the venous system, leading to a decrease in venous return and a decrease in cardiac output. At the same time, the pneumoperitoneum leads to an increase in sympathetic tone, and this sympathetic tone offsets the decrease in cardiac output by increasing heart rate, increasing systemic vascular resistance, and that these two things have a very delicate balance. Normally at intra-abdominal pressures less than 15 millimeters of mercury, your MAP will remain the same or slightly increase. At pressures above 15 to 20 millimeters of mercury, that's where you get the outweighing of the decrease in venous return being greater than the increase in the sympathetic tone. As a result, you see a decrease in MAP subsequently. Now the effects of hypercapnia, again divided in the same way, on the respiratory system, you get respiratory acidosis, the potentiation of hypoxic pulmonary vasoconstriction, increase in VQ mismatching, and a shift in the oxygen dissociation curve to the right. On the cardiovascular system, typically an increase in CO2 when the pH is above 7.2 leads to an increase in sympathetic output, but when the pH becomes less than 7.2, you can get a negative effect, specifically a negative inotropic effect on the heart. To add in those additional points to finish off this model answer, you talk about how a change in position exacerbates either the respiratory or the cardiovascular system. So typically when you go in Trendelenburg, all respiratory effects will be made worse because of the increased cephalic displacement of the diaphragm, while the cardiovascular system may be improved due to the autotransfusion of blood from the venous pooling. When you go reverse Trendelenburg, the opposite occurs. Now this leads us on to our last two SAQs for today, which we've already covered really well in part 1, which were describe the cardiovascular changes that occur with aging and describe the cardiovascular changes that occur with morbid obesity. Both of these questions have been asked multiple times, with pass rates both above 50%. And really what I want to do for these questions is remind you of my structure for a model answer based on my headings. So this includes breaking it down into cardiac, vascular, and autonomic changes. And within cardiac changes, this can be divided into structural changes, conduction changes, and functional changes. The key difference here between aging and morbid obesity is to highlight with functional changes that with aging, an increase in cardiac output becomes dependent on an increase in preload as the max heart rate ability decreases, while with obesity, an increase in cardiac output depends more on an increase in heart rate because the blood volume is already so high and the preload is already raised. The main difference within vasculature is that with aging, you get increase in atherosclerosis process and the natural ability of the endothelium to dilate because of the products it produces decreases, and therefore you get overall increase in systemic vascular resistance as you age. But with morbid obesity, you might get an initial decrease in systemic vascular resistance because the adipocytes act like parallel circuits, decreasing the vascular resistance going through them. But as the disease process continues, you get infiltration of those vessels, leading to an eventual hypertension. This is why the disease process you see in the heart is different for morbid obesity than it is for aging. With morbid obesity, you might first get the eccentric heart, and then you get the concentric heart. With aging, you generally just go to a concentric heart with left ventricular hypertrophy. Now that brings us to the end of today's pod. We've covered a bunch of SAQs, some in more detail than in others, and that's really because I didn't want to repeat the same stuff we've talked about in part 1 with some of the SAQs here in part 2. My next pod will be our final topic for cardiovascular physiology, which will be looking at measurement. So until then, good luck with your studying, and I'll catch you next time on Count to 10.